All right. So where were we? Yes, Dr. Davidoff. Thank you so much for being on the Spoken History Project for the New England History of Medicine Society. How are you doing?
It's my honor. Thank you, Noreen. I am doing fine. Good to see you again, and also really happy to hear that you've chosen interventional radiology as your field. It's amazing that you've come around this way. So good for you.
Yeah, no, thank you. It's again, great to reconnect with you after so many years. I think I
Yes,
was a student of yours maybe I want to say it was 2022 or so. Now we're here in 2025, so
3
maybe
years
that
ago.
timeline sounds fine, but yeah, yeah.
Yes,
I think, radiologists will find each other one way or another.
that's true. That's
Yeah.
true.
All right, great. So I'll just kind of set the stage here a little bit and give the audience a sense of what the Spoken History Project is, and then I'll do a brief introduction for you. So the Spoken History Project is going to be a series of interviews with physicians who have been in practice, or really healthcare professionals who have been in practice for an extended period of time, so that we can understand the changes that have happened in medicine and healthcare over that period to identify themes and really get a sense of how practice is happening today. And so for this interview, we have Ashley Davidoff, who is currently a professor of radiology at the Boston Medical Center, formerly known as Boston City Hospital. So that'll bring me to my first question, Dr. Davidoff. Were you at BMC when it was Boston City Hospital, or was that before your tenure there?
It was before my tenure, Noreen. So I arrived at BMC about 5 years ago.
I
So
see.
it had already become one institution by that time.
I see. And what brought you to the BMC?
So I think I'd always loved to teach, and I was at UMass for about 16 years. And then our family grew to 4 children, and we were living in Boston. And it was my wife, who's also a physician. We had to try and I had to help her with the children because it was an hour away, Worcester. So we decided that I would have to come closer to home to help with the family. So at that time, what seemed to be a reasonable opportunity was St. Elizabeth's Hospital, which was at the time I joined was a combination of an academic and kind of semi-private organization. It was very close to home, and it was a practical decision to go there. After a few years there, I realized, although I did teach a little bit at Tufts, it wasn't sufficient for me. So I had spent many years there because early on, I think the academic mission was far stronger, and it grew to a for-profit organization, and I didn't quite fit in there well. So I decided to come back to purely academics, and mostly because I love to teach. And I love clinical radiology, clinical medicine. And this was a great opportunity.
Great. So I would like to now switch to discussing more your interest in teaching. And to begin with, I'd like to know, where do you think that interest came from? And was it always part of your plan when you were a medical student?
Nice, great question, Noreen. I think um, what I realized about myself after many years was that I needed to understand concepts and principles. I wasn't a type of student who could read and understand. I needed to kind of break things up into principles and then and then try and progress from that. And in struggling myself to learn, I found that it was easiest for me to start at very simple principles and then build up. And once I knew that for myself, I thought I could teach better. I didn't teach detail, I taught principles. I tried to teach principles. And that, I think that was kind of what drove me, that I had to teach myself first, and then through that, I was able to teach others.
I see. Yeah, it is interesting that I often find that people who have an interest in teaching have some, grappling with, the information and trying to distill things down to the kind of essential elements. And from there, you can kind of wrap your head around the details more. So that is certainly an interesting aspect of your career. And just to kind of take an even further step back, it sounds like you spent a good amount of time in all the, big institutions in the Boston and surrounding area. Where was your first introduction into medicine in terms of your initial training? Whether you can talk about your undergraduate experience, if that's where it started, or your medical school experience. Kind of what was your first exposure to medical training as you see it?
So, in South Africa, that's where I was brought up, and that's where I did my undergraduate medical education. I recall one day I was on vacation, and a young girl, maybe 8 years old, was in a motor vehicle accident, was lying on the street. And as we all stood around there, I was certainly, I think I was in high school, I got a sense that nobody could do anything, and I felt this poor person was struggling on the ground, a young girl, and nobody could help her. And I felt that that may have been my initial calling. In South Africa, we went straight to medical school from high school, so we didn't have an opportunity to mature as people. We just had to make a decision and go to medical school. And I think I really loved biology. I wasn't so great at the sciences, but I loved biology. And we did have to do physics and chemistry in our first year, which is kind of the equivalent of the American pre-med school study programs. And I really enjoyed great teachers in South Africa, particularly in cardiology and neurology. And those were my idols. And I spent some time with Professor John Barlow, who was a fantastic clinician and cardiologist. And he used to teach us how to hear the heart by using his fingers on the patient's chest to help us understand the murmurs. And I just loved the sounds. I loved the music of cardiology. And at the time, this was around about the 70s, the apartheid was really something we became much more conscious of, and I felt that I couldn't live in that environment. And Dr. John Barlow, at the time, as it was around about the 70s, a lot of us were leaving and trying to find a place to work and live. He thought that, and I did a kind of mini fellowship with him. I don't know how much you want to go into this because I don't know how much time we have, but basically I did a mini fellowship in adult cardiology, and he said, if you're going to go into adult cardiology, I think you should do pediatric cardiology as another fellowship. This was before doing even pediatrics. So I was in Toronto for a year of fellowship, and it was there that I realized that my mind was not made up for detail. I didn't know this about myself. I enjoyed the cardiology, but I enjoyed the diagnosis, but not remembering the names of drugs and treatments. And that was just my limitation. And so I then spent another year in pediatric cardiac pathology, which I really enjoyed because it was all about structure. And I think that's how whenever I advise medical students, I say, do you like anatomy or do you like physiology? If you love anatomy, you're a structural kind of right-brain person. If you like physiology, you're more of a left-brain person. Anyway, I went on, and when I started radiology, I said, I can't believe this, why they even pay me for this. This is such a lot of fun. It really was who I was, It really fit with my, I suppose, I wouldn't say talents, but with the way I like to learn and work. So that's my story, really.
No, I think, your route to where you are today, I think is very interesting. And, I can, only assume that it gave you a lot of experience, outside of your current field of practice and, doing adult and pediatric cardiology. You are now a thoracic diagnostic radiologist primarily. Is that correct?
That's correct, yes.
Yeah. So, I think it is interesting to speak with people who have sort of a nonlinear path to where they are. And I guess one question that it brings to mind is, Radiology is a field that's undergone a lot of changes, particularly with the technology available in the day-to-day work of that you do. So I'm wondering, were you practicing radiology in a time when everything was fully computerized as it is today, or do you remember a time when that wasn't the case?
Absolutely not. It's I think if you're looking at the history of medicine in the era that I've lived in, it has changed dramatically. And a few stories when I first decided to do radiology, people said, "How are you going to sit in a dark room for all day and just look at X-rays?" And when I started, there was CT was just beginning. There was no MRI, and the clinicians, particularly urology and surgical groups and pulmonologists, there was only the chest X-ray and KUB, so they excelled at reading them because they had the clinical background, and we were kind of demeaned in some way because we didn't have the clinical background. Yes, we were looking at X-rays, but we had no additional expertise. What the digital world did for us was huge in radiology. It enabled us to become a little more sophisticated in the way we worked, in the way we looked at things, what we understood about the technology. And the other subspecialties didn't have the exposure nor the experience to read the CAT scans and the MRIs like we did, because it was a new technology and it was a little more complex than just reading. So it changed the way radiologists were viewed to a huge extent. You almost felt like you were a second-class citizen when you went into radiology at the time. And that you were kind of copping out and you were just wanted to sit in a dark room looking at X-rays. So that, in terms of history and what I've seen, has been a huge change in the way we work. The other big change has been the incorporation of PAC systems. Because before PAC systems, I don't know if you want to go into this now, Noreen.
No, please. Yeah, these are exactly the kind of anecdotes that I think everyone wants to hear. Yeah.
Yeah. Before the PAC system came along, it was, for me, they were glorious years because the clinicians came down and we had eye-to-eye contact with them. I think the patient got a much better deal because of that, because we learned little subtle things that were not in the history, that made us read and re-look at the images a little differently once the clinicians gave us some additional facets of the information. Sometimes they didn't think it was relevant to reviewing the image, but it really made a huge difference, and we developed a great rapport with the clinicians, and they came to trust us because we worked together. When the PAC systems came, a lot of the reading was on the wards, so they read it independently. They read our reports, so we became kind of isolated, which for me was not the most satisfying evolution of the way radiology went. I really welcome the clinicians when they come down, but they don't come down as often as they used to. You can't build trust. They don't know who you are. They just read your reports. And it's really something I think that in some way, I would rather have the PAC system because I think it's helped us compare images before. I can remember stories where the films went, one clinician who needed to review the case downtown in Boston when I was at UMass, took the films out of the film library, and I had to read, and we had to hang the films, whether it was the CT or the X-rays, and we hung the old ones on top and the newer images on the bottom. And if we didn't have the old studies, it was really to everybody's disadvantage. I remember hauling one of the surgeons over the coals. I said, "How can you do this? We needed to read the images," and he had taken the images out. We only had one copy. So the PAC system allowed us to have all the images in one place, to compare, to look at the history of the patient, the imaging history, and it was a huge advantage. So I think in the end, the patient benefited a little bit better because we were able to see old films and see any changes that were important. The thing that came next the Epic. And in the past, we were limited by what was written on the history in the requisition. Once Epic came, we had the ability to look at the pathology, the blood results, and it gave us a new perspective of the patient. And I think that for me is huge, because it's one thing knowing, reading in a vacuum, but if you have some information about the pathology, you look at the case in a completely different way. If it's an adenocarcinoma or a squamous cell, they all behave differently. And once you know the pathology, your perspective and your comprehension of the case changes significantly. So I think if you look at the history of radiology as we went through, first we were not considered real doctors, and then we gained some more respect once the technology came more sophisticated. Thereafter, we lost the clinicians via PACS because they didn't come down as often, although at BMC they still come down quite often. And then Epic has really been helpful in terms of integrating all information.
All right. There is a lot I want to delve into further with many of the points you just brought up. And the first I'll start with is, this idea of how you integrate clinical data with imaging studies and doing that before a time when everything was centralized on a computer. I'm wondering, when you were working with, plain films that you would hold up to a light and evaluate the study that way, how were you getting information about the patient, if at all? Or were you just relying on an isolated piece of data that was the image?
Well, we got a requisition, a history, and that would be a 3-liner or a 4-liner, and that was it. We had people hanging the old films before we came, hanging the old films, and we had the old studies and we had the reports of the old studies, so we got some information from the old reports. But most of the time it was, patient short of breath, rule out pneumonia, something like that.
And then how are you disseminating that information to the ordering physician? So you have the chest x-ray that you're reading by holding it up to the light, and then are you calling someone? Are you having a written report and having a courier take it to their desk? What's that process like?
Again, I had forgotten about this, Noreen. Thank you for reminding me. So we used to have dictate, but not voice recognition. So we would have to dictate, and then somebody would be typing our report, and then the report would come back after they've typed it, which is, a few hours later, and we'd have to correct the report. It was a huge aspect of our work, and I hated doing it because the people who typed, there were often mistakes. Often, I said something, or I made mistakes, and you'd have to sign your reports, and they were, at the end of the day, you hadn't signed your report, you'd get into trouble because the reports had to go out. So in the beginning, it was people were specialized to type the reports. Subsequently, voice recognition came in, and that was a huge advantage as well. But have I answered your question, or was there something more that you needed to know?
So it sounds like, from what you're saying, reports would be dictated, and then it would be like a paper typed up document of some kind that would then somehow get disseminated to the ordering clinician. Is that correct?
Correct. I think before fax, it was faxed at a certain point. I think also we used to write on the images came in an envelope. So there would be a place, patient had chest x-ray on this date, and you'd write the report. So on the envelope, and then that would go into a central record keeping place. And if somebody wanted to look at the images, they'd come in there, and the typed report would also be inside. And I don't remember how the clinicians got to the report, but the report sometimes would be inside these envelopes that would be kept in the file room. They'd come and look at the images, and they'd pull out the report, paper copy of the report. There may have been some distribution to the clinicians as well, but it was before fax. So I think that my sense is that they were just in the envelope of the image.
I see. And then can you please timestamp when you recall PACS being integrated into your practice? And how far into radiology in terms of your time practicing were you?
So what I do recall was that when I moved to St. Elizabeth, which was the year 2000, I think, or 2002, they were just introducing PACS into St. Elizabeth, and I was so excited about this because it did bring something really helpful to us. So I would say around about 2002, when it was around about between 2000, early 2000s, that PACS started to become integrated into our system. So it's not that far off, it's just 25 years ago.
I was going to say that, it's difficult for me to imagine practicing in a time in which you didn't have PACS, and to know that it was, during my lifetime is actually very surprising to me. Yeah. And to follow up then, it sounds like you were, in general, pretty enthusiastic about embracing it, and, it helped your practice a lot. Were there dissenters, among your contemporaries at the time? Did you feel like there were some who were resisting the change a bit, or was everyone universally excited?
I think from the radiology perspective, people were universally excited. I think people who used to type, they lost their jobs, of course, if they were trained as typists in medical, for medical terminology, they lost their jobs. Their jobs started to become redundant. So, but I think from the clinician and radiology point of view, it was a huge step forward.
I see.
I was so excited to have it, just to be able to compare old films. You wouldn't have to wait for the file room to bring you the old films and hang them. If you wanted to look at a nuclear medicine study, we didn't even have those in the same folder. We had to phone or find out. So there was a lack of integration, and it's the integration that I think brings better care. This is what Epic has done as well. It's helped us integrate the information so that in the end, our decisions are far more educated.
So then would it be fair to say that over time you think, all these big technological changes that have kind of, really revolutionized the field, it's all been in the end goal of improving diagnostic accuracy and care for the patient? You think that has all improved?
All except our communication with the clinicians has decreased. And as I said, sometimes there's subtle nuances in the patient's history that they may not think is important, or that we may not think is important, but in the questioning and in the communication, there's definitely a huge advantage, something we've lost a little bit, but they still come down, I must say. It's not totally lost.
I see. So then during your training, during your radiology residency, was it all reading chest x-rays, KUBs, CT scans? Was that kind of the extent of imaging you were exposed to for diagnostic training?
So in my career, I did interventional radiology first because I had done this cardiac stuff. So when I applied for my residency, there wasn't a residency spot, but Herb Abrams, who was a pioneer in interventional radiology and angiography, knew that, was a cardiac radiologist, said, why don't you do the fellowship first? So there was already interventional radiology at the time. We had just started. I remember our first alcohol embolization. And then when I did my residency, CT was definitely, the MRI was evolving. CT had, I started my residency in 1980 or 1979. And MR was just evolving. CT was already established. Ultrasound was already established. Fetal ultrasound, OB ultrasound was just evolving as well.
I see. And then, you work with a lot of medical students, other trainees. I'm sure there's a lot that differs between their current training and the training that you went to, but can you maybe discuss, a few big differences you perceive? And it can be anything from the content of their education, or the modality of their education, whether there's a lot of Zoom time, or you feel like there's, equal in-person time, just, things like that you can think of off the top of your head.
You're talking about resident education or medical student education?
Well, I guess we can start with either, but I guess since we can talk about resident education, sure.
So resident education, when I was being trained, the board exam was an oral exam. So we all feared that because it was we had to travel to Louisville, Kentucky, and you had face to face with your examiner. There was the anxiety component, the compatibility with the person who was examining you. It depended on the questions you're going to be asked, depended on your psyche, your anxiety level. And as a result of this type of exam, our training in the noontime conference was more, we were all called up individually to the board, and we were always put on the spot, each of us, at some time during the conference. And it was a case conference. So we would be called up and you would be asked to discuss the case. And this was in preparation for the oral exam. In teaching trying to incorporate this type of teaching to the residents up to now, there have been some residents who are such confident people, but I've said, how would you like this type of exam where you called up? And some of them would say, I don't want to embarrass myself. However, what's happening now in radiology is that the board exam part of it is going to be an oral exam. So we may be going back a little bit to that kind of teaching where you call an individual up and you ask them the questions. So it has changed a little bit. The Zoom for sure has made a difference. I think, for example, people who are working, our local residents who say work at the VA, can't attend the noontime conference in person, so they attend remotely. It's not the same, but it's something. They know the people, they know the cases, they learn. And I think that it's different, but it does accommodate people who are unable to come to the conference. I think the other thing that you should probably also realize, and maybe it's worthwhile pointing out because you've asked about Zoom, is how the radiologist's role has changed because of Zoom and because of COVID. None of us had workstations at home before COVID. And now many of the faculty members, all of us, have workstations at home, which makes a difference in lifestyle, particularly for people with young children. I prefer to go in, but there are people whose lives are very busy in the family side and also are very busy on the clinical side, and Zoom and remote stations in radiology has helped a lot for that. We've lost a little bit, but we've gained a lot. So it's worthwhile discussing.
Are they something you envision will be enduring? Is the institution supportive of continuing that effort?
Yes, I think so. It's more that I think the people who suffer a little bit from this are the residents, because it's better for them to have, like we suffer when the clinicians don't come down, we don't have the eye-to-eye contact, all the little smaller things that come up arise. In order for you to teach the resident, if you're at home, you have to make a call. It's a little effort. Whereas if you're in the reading room, just call them over, and you say this is, and teach from that perspective. So somehow progress is always, hopefully 2 steps forward and 1 step back, something like that.
I see. Along those lines, can you briefly discuss your experience and observations with the volume of imaging modalities that have, or not even the volume of modalities, but just the volume of studies that have been ordered, more recently now versus when you first started practicing? I imagine there's a general trend upwards where you're seeing a lot more scans every day and there's just a lot more information to take in. Is that fair to say?
I think that's really fair, and it's not only the volume of the number of studies, it's the volume of images that we have to go through and have to read. So whereas you can imagine reading a chest x-ray and there's one image, and then you look at the lateral, there's another image, but now a chest CT or a cardiac CT is up to 2,000 images. And you've got to be able to change the way you look at things and how you read them. Of course, we have scrolling, and you scroll through quickly, and that has a disadvantage. But in answer to your question, volume definitely increasing. And I think from my perspective, it just shows that the role of the radiologist has increased because there's less time for the clinician to examine the patient, because they're given 10 or 15 or 20 minutes to examine the patient. And a CAT scan gives you a significant insight into all the organs, more than the clinician can examine, because we're seeing the inside of the body. Of course, it's radiation, and of course we have to be sensitive to, ordering these, that the clinician orders them. But it is, in the end, a way to make a diagnosis. And once you can make a diagnosis, then you can treat. So I think definitely the studies are increasing in number. We're feeling the pain. There are fewer radiologists. I don't know why. Or the demand for radiologists is greater than we have available. But it's still manageable. It's still manageable. The other thing that has also been helpful is remote reading through, from other countries by board certified radiologists. So that's been another huge advantage. We used to be working in the middle of the night to read an urgent case, and now we have our own radiologists, who read in the night and then take off in the morning. And there's the remote reading, as you know. So that's another big thing. Because of technology, we're able to read remotely at night and during the day.
Are there, the remote reading is currently ongoing right now at your institution? So
yes,
you have collaborators around the world who are helping take on the caseload?
At the moment at BMC, we have a team of our own doing that, because I think they get a little more extra time during the day. And these often are people with young children, so that, one of the parents can be there during the day, and the other parent, if they're not working at night, they can be working during the day. So it is a change in the way families work as well, because as a radiologist, many of our both male and female not many, but there's a team from our group that work only at night, and then they are with their children during the day.
I see. And what is the landscape for artificial intelligence like in your experience right now? Is it something that is a big presence in your day-to-day? Is it something that is going to be soon that you anticipate, or just in general, what's the status with artificial intelligence right now?
It's going to be really, really important. We haven't got the software yet at BMC, but I do know people who have got it, where the reports get generated very quickly. I think it can select out overall, if you have 100 chest x-rays to read, it can select those that are probably normal. So then you already have a bias that these are probably going to be normal. So you read those quicker, and maybe at the end of your 100 pile, and you read the first 50 that there's AI suggests may be abnormal, that you read those and have focus on those. The reports being generated, I don't know enough, but I do have a friend who's in that world at a higher level, and he said there's always going to be a need for human incorporation into the excuse me, the final word on the case. He said you can't he doesn't think you're going to be able to totally trust AI, but I think it's going to be very helpful. And for those people I've spoken to who have already got it, say it's incredible. It's really going to be helpful.
Along with the broader implementation of artificial intelligence, are there efforts to concurrently increase the workforce in radiology that you know of? Are they going to kind of couple the technological advancement with hiring more people? Because it sounds like from what you're saying, there is a worker shortage as well.
Yeah, everybody would like to. There are many spots, I think, available for radiologists, and I'm sure people would like to hire more for the number. I mean, there's a lot of burnout in radiology, believe it or not. I think after COVID, I was at a recent meeting just in April and in March, and there was a lot of discussion about burnout in radiologists, just because the demand to do a certain number of cases per day. You know, people are under the gun to do that a little bit, a lot. And so, and I think this is throughout medicine. There's a lot of issues about the stresses that we're all undergoing.
Yeah, it certainly sounds like, you know, when you were mentioning that the rise in the number of imaging studies being ordered is kind of paralleled with the decreased number of time that clinicians have to actually examine the patients and, you know, do a good physical exam. And then that transfers over to more imaging studies being needed. And then you have to introduce, I guess, I don't know if there's like actual quotas or what the right term is, but just the pressure to read a certain number in a certain amount of time. Was there a time you recall when there really wasn't that pressure? You just kind of took whatever came into the door and, you know, you were just like, we'll handle the cases as they come, but like, you know, there's not a certain number I'm keeping track of in the back of my head. Was there a time like that?
There definitely was a time. I think it was somehow because I like to teach, they used to pick, excuse me, peg the number of cases you read to a reward system, so you'd get more money at the end of the year. And I just could never get that. I was never part of that because I like to teach. So, and I said it doesn't really matter. It's more about self-fulfillment and doing what you think is the right thing. But on the other hand, there are patients waiting for your read, so you don't want to leave. It's definitely a difficult thing. One thing I was thinking of speaking to you about, and maybe you have other questions, but before I forget, when I was at UMass, I was an interventional radiologist, and this was before CTA was able to be used for aortic injury. And we used to be called in to do an aortogram for patients who had a mechanism of injury, which meant they were traveling at about 35 miles an hour, and they had an accident. And because it was a decelerating accident, even at that speed, you couldn't tell from the chest x-ray whether there was an aortic injury. So we would be called out, and I remember traveling to UMass sometimes 2 or 3 times a night to do an aortogram, which was negative. And as the technology evolved, we don't do aortograms for trauma anymore. CTA evolved, and that's what the standard of care is. So I just thought I might mention that because that is definitely a significant historical event in the evolution of technology and how it perhaps changed my career in some way. Sorry to interrupt there, but I didn't want to forget that.
Great. So anything like that you can think of, I think is extremely valuable. And to that point, can you think of any other sort of ways that you practice now that, you know, might have been different in the past, such as, you know, modalities that are currently just out of vogue or no longer required, or, you know, less invasive ways to get the same information from a patient or something to that effect?
I think interventional radiology, and I know this is your new field of endeavor, has advanced significantly. And I do remember being involved with percutaneous biopsies and percutaneous treatments, but it has become a field that is so sophisticated and so needed that I think you've chosen a great field, and it's a field that you feel, you know, as radiologists, you kind of feel that you're a service, but you're not actually changing the patient's. Well, you're not treating the patient. You're diagnosing and you're helping to treat. So, but in interventional radiology, you feel like you're doing both. And it's evolving with microcatheter techniques and microwires and ablation techniques, and that's I think is an important thing. I thought I might just tell you one other story, which
Please.
It's about coming to this country. I had done this adult cardiology fellowship, and I had already cathed some children and some people, some adults in South Africa. and we never used abbreviations. So I came and I did my fellowship in Sick Kids in Toronto, and I think there was a child who arrested, and I was around, and they said, go and get the epi. And I said, what is epi? And they looked at me because I'm supposed to be the fellow who knows cardiology and knows how to arrest, what an arrest. And it turned out that they wanted epinephrine, and we hadn't used abbreviations. And I felt so embarrassed when I heard this story. The other one was put the catheter in the IVC, and I said, "What is the IVC?" Just this guy who's done a cardiology fellowship. And he comes and they ask him to put the catheter in the IVC. So that is a kind of a story that shows, what happens historically in the background, in your background, and how, coming in from a different culture, things can be misunderstood or miscommunicated just because of, your own personal background. I thought I should mention that story because I've told it to so many people, and it's kind of funny.
Yeah, it's very much a when in Rome kind of moment. So
yeah.
So to that point, then, what's your perspective on abbreviations and acronyms now? Do you use them in your practice and reports?
I must say that when I go into Epic and I see the way things are abbreviated, it's really difficult because they're new drugs and I just cannot understand them. I've got to go to Google, and I've got to chat GPT, and I've got to try and understand what the abbreviation means. The other thing I think is worth mentioning is what's changed is I think the social media world, when I dictate a report, I almost always put in before I start the impression, I almost always put the age of the patient, the sex of the patient, a brief summary of the history, and then what the person's clinical problem is, and then the second sentence I say what my answer is, and which is what I think may be going on, and then I have associated findings and incidental findings. And for me, to start out with a perspective and then to evolve the story from there is almost essential. I just can't read a report without doing that. To teach that to the residents is really difficult because their impressions are bullet points. And when I look at my kids who are about your age, they don't like Facebook because Facebook has got too much embellishment. Instagram and whatever else you use, TikTok, has got just the facts, just the answer. And I think that has historically, has become integrated into the way we communicate now. I think it's less words. That my residents tell me the clinicians already know what the age of the patient is, what the sex of the patient is, and what the background clinical history is. They don't want to know that you know that. They just want to know, has the patient got pneumonia or not? They don't want to know, this. So, but there is definitely a cultural difference and a generational difference, and I think it's a result of the culture that is present now, which is, very much quick communication, and it's who knows what's right or wrong. But for me, I just feel I have to put my head around the case before I give my impression.
I see. That's very interesting, and it makes me think back to the discussion we were having earlier about just this feeling of everyone feeling pressed for time. And I wonder if this abridged, abbreviated version of everything is a response to that. And I don't like you. I don't know what the answer is, but it is interesting to ponder, certainly.
That's a good point. I didn't think of that it's about time and speed, and moving on. Yeah.
I wonder. And so I kind of want to backtrack a little bit, and I wanted to say, I know you had asked about time earlier, and for the purposes of this interview or discussion, we can go for as long as you'd like, but if you have any time constraint, we can certainly tailor it to that as well.
No, I'm fine. I'm
okay,
fine, Noreen.
okay.
Thank you.
Oh yeah, of course. And so for the next portion of this discussion, I wanted to talk about, you meant the sort of business of medicine and the sort of corporatization of aspects of practice. In as much as you are comfortable commenting, I'd like to know, you mentioned, I think you left Tufts because of the more corporate atmosphere and you didn't quite fit in with that. Um, have you do you believe there is any sector within medicine and diagnostic radiology that is really safe from that influence anymore? It's hard for me to imagine practicing anywhere where the sort of corporate aspect of it isn't something that you're forced to confront on some level.
I think you're absolutely right. I just want to correct. It's not Tufts that was the for-profit. It was an affiliated hospital called St. Elizabeth's,
Okay.
which became Tufts is still for a non-profit organization, but not for-profit organization. This was a hospital that was affiliated with Tufts that became a for-profit organization. And I remember, and I'm sure Dr. McGee would remember as well, when the time when medicine changed was when you could advertise for your services. Before that time, a doctor couldn't advertise their services, nor a dentist. Once that became part of it, that was the beginning of the change. I think it's got to be, it's okay for it to be integrated like it is, because everybody has to feel valued. They have to be paid for what they do. It's just a matter of the CEO of the organization, Stewart, I don't know what to say, and I won't mention names, abused that system for selfish reasons. And as a result, for example, I lost a pension because of that, because the company went belly up, and I lost a pension, as did many others, and many others lost a job. And the upper administration took more than they should have. And that's where it becomes evil, when it's used for selfish personal reasons. I have friends who are researchers, and they tell me that the government, I don't know what's happening now with Trump, but the government is now, what is the word I want? Contracting out to private organizations for research. So, for example, if you have a research idea and you submit an NIH grant, this is before our recent events here in this country, that the government would either give you the grant and help you facilitate that grant through corporate organizations, so that they acted as middle people for the research. And I think there is something to be said about the efficiency of an organization that is dedicated to develop the product, market the product, and in the end, it is about money and finance. But the combination of those two, where there is some kind of control over the way it gets executed, is probably a good combination. If it's too biased towards making money, like what happened at Stewart, then it's not good. If it's combination of advancing science and in the same way making it an economic event, then yes, it's good. Excuse me. So I think in the end, even although it's become progressive with the involvement of money, if if it's well thought out and well used, I think it's going to be to the benefit of medicine and science.
I see. Thank you for providing that perspective. So to discuss the next thing I wanted to ask you about was, we talked a lot about the different innovations that are changing the practice of radiology. What do you think are the biggest challenges that you think innovation and technological changes will need to address? I think we spoke a little bit about the workforce shortage and things like that, but are there other things you think that the profession or the practice could benefit from addressing?
It's a good question. I'm not sure I have an answer. I think AI is going to be really, really important and more important. And I think we have to embrace it and use it judiciously. I fear that it's going to take a lot of jobs away from young people. My son, for example, is a writer, creative writer, and he's been in a generation where they needed creative people to write, and I think that field of copywriting is going to change. It's going to be less and less people. So we have to. I want to foresee a time that AI will create jobs for more people, and how that can be done, because I think there's no way that it won't take jobs away, but is it going to create jobs? And among radiologists, I think it'll always need a radiologic input, but I think it may result in fewer radiologists. I don't know.
I see.
But just for your purpose, you're always going to be needed, because I don't think AI can, do anything about hands-on technique. Or it'll help, but it won't take it away, I don't think.
Right. Yes. And even I think in the world of diagnostics, like patients can have, various contrast reactions. You do some procedure-based things, whether, putting in a line or a tube or something to that effect. There's always that aspect of radiology as well. Fluoroscopy, things like that. So
yeah. I should mention, Noreen, is that when you rotated through us at BMC, I had started this club with medical students about integrating the outside life with the inside life. We call this program Behind the White Coat eventually. So I think that aspect is an important aspect we should think about very carefully, because it's not only about you're interested in history, but at that time we said you're interested in history, but how do you integrate that with your with your education? And we've been doing that at BMC quite a lot, and I think trying to make people not just a student of medicine, but a student of themselves, and how to integrate their outside interests with medicine, I think is something that is not present in many institutions. And I think it's really, really important, because it's not only about filling the student with facts and numbers and, it's about trying to make the student whole, even when they're in medical school. Time is always a problem, but I think it's to great detriment of our society that we don't focus on people's talents and their interests as they go through medical school. So that's my mission now. As you know, I have a project called The Common Vein, which identifies the concept that everything is integrated. If you're playing music, the way you practice music is the way you should practice skills in radiology, in procedures, as a surgeon, looking at the images. All those things are integrated, and that's what I think we should perhaps look towards, is making people as whole as possible and as enriched as possible. And the way to do that is to incorporate the person behind the white coat with the person inside the white coat.
That was a very nice sentiment, Dr. Davidoff. I couldn't agree with you more. And I think that may be a good place to end. But before we bring the interview to a close, I'd like to ask, are there any other points about the changes in medicine you would like to discuss? And if not, if you feel like we've covered everything, I would like to know if given the choice to do it all over again, would you still choose radiology in its current form with all the changes it's going through?
Definitely, definitely, definitely. I think people have to know, I shouldn't say talents, but what what they can best do. It took me some time to know that and understand that about myself, and that's why I had some kind of circuitous route getting to where I wanted to go, where I eventually learned who I was and what I could do. And I think if medical students are listening into this, I would say decide whether you love anatomy or you love physiology. And based on that, your next step in choosing what direction you should take would be much easier for you. Even although it was a circuitous route, I think I learned a lot on the way. Things that I learned particularly in pediatric cardiac pathology, there were principles of evaluating the heart. I still use and teach today. I haven't ever forgotten them just because it was such a profound experience. And it gave me a different, I wasn't on a railroad track, going from one to another to another. I kind of deviated. And in that deviation, even although it was time, it was to my benefit. I had a different perspective on the field in the end. So same thing as you. I think you've taken off and you're going to see your field from a different perspective, and it can only enrich your career in the future. It seems hard in the beginning, hard while you're on your way, but when I look back, I wouldn't do anything different.